in our Flowood and Madison offices and also in most of the area hospitals. So particularly pleased to be involved. I come today not only as a practicing doctor, but also as the chairman of it's a little feedback. Chairman of MIPA, which is another acronym for you, the Mississippi Independent Physician Practices Association. And it's an understatement. I think everybody here knows this to say that the practice of medicine in our country has become increasingly complex. You can start with the demands that come with a dizzying pace of just the scientific and technological advances that occur every day. And then on top of that, layer in the fact that practicing providers have been expected to become experts in the Byzantine maze of third-party payment for services. And if you think about even the smallest of independent practices, which are, by the way, increasingly rare, as you know, if you just look around, the solo provider, the small practice, they've been forced to retain the services of billing and reimbursement experts, specialists, so that they can pay their clinical staff, their employees a fair wage, cover their other expenses, and then hopefully have some dollars left over to pay themselves at the end. Our hospital struggles are well documented. You see things on in the news every day in the media about how the forces are impacting them. It's a little bit, I think, less well publicized how your average practicing physician, deals with some of these forces. Sometimes tempting, not only for my colleagues, but also for policymakers and legislators, just to kind of, throw up our hands. Certainly that's true for me, and resign ourselves to the idea that there's nothing more that can be done about a lot of this. But those of us at MIPA and certainly other healthcare interest groups, we're just not ready to quite ready to throw in the towel. We're encouraged that the legislature's members, through the enactment of Senate Bill 2401 this past session, are willing to take a deeper dive into the troubling state of healthcare affairs that we're all here to talk about. Not going to waste time with history lessons on how we got here. I know a whole lot more about the pancreas and the liver than I do about policy and legislation, but the causes, from my perspective, at least as a private doc, seem too complicated and numerous to hash out in this forum. But what I can tell you is that it's past time for those of us on the front line, the ones that actually deal face-to-face with patients. I just left someone 20 minutes ago. I was a little bit behind schedule because telling somebody, is getting a screening colonoscopy that they have a colon cancer, and that changes your life immediately. The people that are on the front line, we need to take a more active role in developing governmental healthcare legislation and policy. We've got national groups, the AMA, the American Hospital Association, many more. They continue to work hard at the federal level to create change. We at MIPA are excited to join efforts with state organizations like the Mississippi Hospital Association, Mississippi Healthcare Collaborative, the State Medical Association. I hope we can all work together in this next legislative session and the years ahead to make a difference for our colleagues as well as our patients. And as for our organization, MIPA, we've devoted a lot of time and thought as to how this committee can improve the delivery of healthcare in our state. One of the themes that recurs time and time again in our discussions and in our deliberations is how can the average physician gain more control over the actual care of our patients. A lot of us, when we went into this line of work, valued or sought the independence that you get with a one-on-one patient interaction. When you consider the incredible complexity of prior authorizations, post-care utilization review, bureaucratic delays, and other forms of legal and clinical second-guessing that occur every day in our individual practices, it's really sometimes amazing that any of our patients get treated in a timely fashion. The legislature has already taken an incredibly bold step toward addressing these problems with the passage of the Mississippi Prior Authorization Reform Act in 2024, the prior session. The legislation has been lauded nationwide and as a landmark accomplishment in patient care, and as our chairman can attest. It's now under consideration by the National Conference of Insurance Legislators as model legislation in this area. We're truly grateful. I can't emphasize that enough for what's been done. We also thank Commissioner Cheney and his staff for acting quickly to promulgate regulations to enforce the act. But, there's always the but, especially in my line of work, there's still so much to be done. There's much that can be done here in Mississippi to correct this decades-long drift. So, just presenting kind of a high-level framework here we'd like to present a few concepts that we think are worthy for this committee's consideration. There's much we could do to give physicians and hospitals a greater measure of control over the care of our patients. And we believe that this goal is worthy of our time and attention. And again, appreciate very much this opportunity. I'm going to ask Mark Garriga to follow me and give you a few more thoughts.
Well, my name is Mark Garriga, and I represent the Mississippi Independent Physician Practice Association. And thank you, Dr. Underwood, and thank you, members of the committee, for this opportunity. It's been my pleasure to represent MIPA for the past 4 years. And in that period of time, I've come to appreciate how difficult it is for the average physician to not only serve their patients in the most professional way possible, but to also operate, in most cases, what we would call a small business, although some of those small businesses may have a few hundred employees. The operation, I've come to learn, of a physician office comes with the usual share of business challenges, things like HR issues, the rent, fee collections, advertising, etc. But if you add to this the fact that their customers, and that's their patients, depend upon them for their health and in some kinds their very lives, you begin to understand just how difficult their jobs are. Now, of course, that was not the reason that this committee was formed. The legislation references the Patient Protection Act of 1995, and which regulates, as you know, managed care plans, and provides that the committee will study and make recommendations regarding certification of health benefit plans and health insurance issuers. Now, the question that we're asking today for you to consider is that maybe 30 years later, it's time to revisit this subject. Now, what we are talking about when we talk about, or what are we talking about when we talk about provider networks and provider agreements, managed care plans? Well, we know academically what those things are. And of course, many people in this room are experts on this subject, and I don't profess to be one. But if you're a physician and you'd like to price your services to make a profit, and I know sometimes that word profit in healthcare is a dirty word, but you have to make a profit. You make a profit to pay the rent on your building and to keep the lights on, to maintain patient records, to purchase equipment, and et cetera. But what if I told you that there was a third party, not the patient, but a managed care company you had to sign a contract with before you could ever see their insured, and let's just call her Mrs. Jones. And that third party told you exactly how much you could charge for your services, and you could not charge either the managed care company or Ms. Jones a cent more. And what if that third party controlled almost everything about not only your treatment of Ms. Jones, with an army of contractors at their disposal to decide what treatment protocols you should follow, but also things like how many weeks later they would pay you, how much they would pay you, how much you must discount your prices, details about the medical care they would pay for, and in their view, what they wouldn't pay for, and the dozens literally dozens of other conditions under which, if they are of the opinion that you didn't satisfy them, you might not get paid at all. And what if their contract was basically non-negotiable? You had to take it or leave it to treat Ms. Jones. And if you didn't sign the non-negotiable contract, but Ms. Jones still wanted to be treated by you, the managed care company would still pay you, but a much smaller amount. And the way they interpret the law, you would not be able to be paid a cent more. Now, this is the situation the average physician in our state confronts every day. Dealing with third parties, managed care companies, whether they be insurance companies, third-party administrators, utilization review contractors, the state Medicaid program, the federal government, just to get paid for their services. A job that can often require a significant size staff, even for a small physician practice. Now back to our example. You might ask the question, if those managed care contracts are so one-sided, why would anyone, any healthcare provider sign it? Because if you're a healthcare provider and you have any hope of treating the almost 1.2 million individuals insured under our state, under a group health plan or individual policy, that's not including Medicare and Medicaid, you're increasingly dealing with a handful of companies. And when it comes to group health plans, one company. Now, that's not an exaggeration. Consider the Department of Insurance's presentation during our last meeting. This slide was only part of an excellent presentation by the Department of Insurance addressing the topics in SB 2401. But this particular slide is one that we ask you to consider in greater detail. The slide had a column for market share for small groups. Small group plans, there are 82,632 individuals in those small groups in Mississippi. The largest insurer has 77,945 of those individual lives. That's a market share of 94%. Look at the large groups in Mississippi. 190,882 individuals with 162,989 belonging to the largest company, 85% of that market. Look at the uninsured groups, and these are basically the self-insured plans. 622,187 individuals, 600,941 with one company, 96% market share. So the totals, in case you're keeping up, 895,000 individuals, 841,000 with the largest company, a total market share of 93%. Now imagine if you were, say, not a physician, but you were like a real estate agent or an automobile dealer or an architect or any business that depends on the ability of your customers to access financing to use your services, and 90% or more of your customers had to use the same lender. You would be at the complete mercy of the rules imposed by that third party. And that's where healthcare providers in our state increasingly find themselves. Now, the question I guess we have for this study committee to consider, is there anything our legislature should or could do about this? I think the first step has already been done. In solving any important problem, you have to realize that there is some problem to be solved. And for whatever reasons, the health insurance marketplace has not produced the type of competition that we all know makes for any kind of healthier competitive economic system. Now, this is how the American Medical Association in a recent report described this challenge. and I think it is worth repeating here today. These are important questions of public policy because the use of market power harms society in both output and input markets, and that's important to consider. When an insurer exercises market power in its output market, the sale of insurance coverage, premiums are higher and quality of coverage is lower than in a competitive market. And when an insurer exercises market power in its input market, that is physician services, payments to providers and the quantity of health care are below competitive levels. In short, the exercise of market power adversely affects health insurance coverage and health care. And that's from their most recent 2024 study. So secondly, we're asking this committee to look closely at this system we've created and that has resulted, and for members to ask the hard questions. Questions like, are there things that we can do to help ensure that network healthcare providers are treated fairly? And these are just some ideas that we're throwing out for your consideration. Maybe there shouldn't be allowed any unilateral contract changes. After a contract has been entered, should a managed care contractor be allowed to modify a healthcare provider's network contract, including pricing, without notice in some cases, or any agreement of the provider? Legislation could provide mutual written consent of both the insurer and the provider in at least 60 days before the changes become effective. What about transparency and pricing? Some health insurers and their contractors make it extremely difficult, we are told, by our members and other participating providers to know in advance the fees they will be paid for covered services. They should be required to provide participating providers with easy and complete access to current fee schedules. What about no retaliation? Any insurer or its managed care contractor should not be allowed to engage in any retaliatory action against a healthcare provider simply because the provider is exercising its rights guaranteed by the Mississippi Constitution to the courts. For example, a provider who appeals a reimbursement decision or consults a regulator, or a provider that challenges the way the contract is being interpreted. Billing disputes are very common, as we all know, in managed care. Health insurers and contractors could be required to adopt a formal billing dispute external review process posted on the portal that establishes a formal process to resolve all billing and payment disputes and allows providers to obtain review by independent review organizations, if needed, and in a timely fashion. But what about the providers who are not even in a network, for whatever reason? There are lots of things that we could do, just a few. We could do a better job of facilitating assignment of benefits. It should be easy for providers to submit assignment of benefit forms when they are out of network. Any process or procedure employed by an insurer or its contractor to make this difficult is not good for providers, and I assure you it's not good for their patients. We could standardize AOB forms. For example, it might be a good idea to develop a standard assignment of benefits form that can be used by any provider for any insurer or its network to make the whole process easier for everyone. And providers shouldn't be required to accept low out-of-network payments if they don't want to. Clarity is needed on the question of what exactly is a balance bill. There are at least 2 Mississippi Code sections on the subject. This is because 83951 provides that a payment by an insurer must be considered payment in full. That makes sense if the provider has been paid the full network amount. You accept the network level payment, you're bound by the network rules. But what about those situations where the payment is much lower, or where the provider doesn't want to accept the payment made by the insurer network at all? Legislation can make it clear that providers are not required to accept low out-of-network payments made by an insurer pursuant to an AOB, and thus are not prevented from billing the patient for the full amount of the service or at least the full network amount. And there are other reforms that we can consider. I know time is running short, and I'll go through these quickly. We've already taken the first step with the presentation by the Department of Insurance. There needs to be renewed focus on market share. We need to understand what the problem is and what the market shows us. And maybe there is legislation that could help us accomplish that as well. What about examination of so-called charitable foundations that are used by some plans or their insurers? The Department of Insurance has far-reaching authority to examine, quote, the activities, operations, financial condition, and affairs of all persons transacting the businesses of insurance, end quote. Maybe we should consider clarifying the agency's authority not only investigate these things, but charitable foundations affiliated with licensed health insurers and their contractors, and to also make those results public. After all, understanding where the money came from to fund such institutions, we would argue, is in the public interest. And lastly, authority to examine excessive surpluses. Now, I know this one is going to be controversial, but let me explain. Mississippi law currently allows the commissioner to determine whether an insurer's surplus as regards policyholders is reasonable. And consistent with the National Association of Insurance Commissioners model, our current law is designed to prevent insurers from becoming insolvent, not to regulate their holding of excessive reserves. But some states, like the state of Maryland, give their insurance commissioner the authority to determine whether surpluses are unreasonably large after a due process hearing. After all, patients, employers, and healthcare providers have a vested interest in fair pricing of premiums, benefits, and payments to providers. So in conclusion, let me just say once again how appreciative we are of the work of this committee and appreciative of the opportunity to be here. We're grateful to our physician members and for your attention to their concerns. And we truly hope this is just the beginning of a dialogue on what we believe are very important issues. Thank you, Mr. Chairman.
Thank you so much, Mark. For those of you who weren't active in this Capitol building 33 years ago, Mark Garriga and I were freshmen in the House of Representatives. And some of you may not have been born 33 years ago. But Mark also served as Chief of Staff to Governor Fordyce. And I'm hoping when you retire, Mark, you'll write a book on that experience. All right. Next, we heard last month from the mobile medical bus, which was a very interesting presentation about medical care in our rural areas. And we have a nonprofit, But God Ministries. And Aaron Sisk, our committee member, is going to introduce this presentation.
Thank you, Mr. Chairman. I have the privilege today to introduce this group to But God Ministries and Mr. Stan Buckley. I was introduced to But God about 7 or 8 years ago. And to me, it was like, this is the best kept secret in Mississippi, even though it's not much of a secret. They've done amazing work in Haiti, transformational work in Haiti. And Stan looked at our own state and said, we've got communities that are suffering the same way as these folks were serving out of the country. And so they set up shop in Jonestown, Mississippi. If you've never been to Jonestown, it's right outside of Clarksdale. Population approximately 1,500. And the work they have done there is astounding. I encourage everybody to go up there and take a look. But I suggested having Stan here to talk because a big piece of them transforming that community is tied to healthcare and bringing healthcare back into that community. The problem we've run into is a sustainable financial source to support that over the years. But hopefully I didn't steal too much of your thunder, Stan. I'll turn it over to you.
Thank you, Mr. Chairman. Thank you, Aaron. My name is Stan Buckley. I'm the founder, executive director of But God Ministries. And we're very excited because somehow, some way, we developed a plan. We figured out how to provide access to health care to people in our state who do not have access to health care. And in this model, it's neither complicated nor hard to do. Let me say it again. We figured out how to provide access to health care in places in our state for people who do not have access to health care, and the model is neither complicated nor hard to do. Now, I want to tell you just a little bit about us to give you the full understanding of who we are and what we're doing. We're a nonprofit established here in 2011. Our home office is up in Madison. Our purpose is to share the love of Jesus Christ through building sustainable communities around the world. We're currently working in 2 communities in the country of Haiti and you just heard in the Mississippi Delta town of Jonestown, which is in Coahoma County, out from Clarksdale. And we work in 7 areas or spheres. And we've come to believe that all 7 of these areas are necessary to have a healthy community, whether you live in Jackson or Madison or Jonestown or London or Paris or wherever. And we use this word spheres, and here they are, the spiritual. We teach people when we go into community, there's a God, He loves you, He cares for you, and because of that, your life has value and worth and dignity. We do the physical, that's medical and dental clinics for us. H2O or clean water, E is education, the R is roofs or housing, the second E is economic development or jobs, and the final S is soil or access to healthy food. And I happen to live in Madison. I don't want to take any of these spheres, any of these areas out of my community. And because they're important in Madison, I think they ought to be important in everybody else's community, especially right here in our home state of Mississippi. So we're focused on Mississippi. I just want to give you one slide, though, give you some quick idea of what we do. In Haiti, we have 2 locations, 2 churches. We have 4 medical clinics with 6 full-time doctors. We're treating thousands and thousands of patients each year. We have 7 schools with over 2,500 students who are fed and educated daily. Many of these kids would not eat every day otherwise. We've built over 300 houses. We've got about 150 employees. We partner with schools such as Georgia Tech, Belhaven, Auburn, Alabama, Kansas, Loyola of Chicago, lots of different universities that we partner with. And that's great. That's in Haiti. So after working there about 5 years, we decided to turn our attention here to our home state of Mississippi, where I was born, grew up, and educated and live, and my family's all here. What can we do about our state? Because you may have heard we have a few challenges here. So what if we took the principles we learned and applied them here, right here in our own state? So we ended up in the town of Jonestown, which frankly I had never heard of. Been here about 60 years, and I had never heard of Jonestown. I thought that's where they drank the Kool-Aid. You remember years ago in South America? And so I still don't drink the Kool-Aid in Jonestown here. But anyway, we're up in Jonestown in the Delta. And just to give you some idea, we have a headquarters there, what we call the Hope Center. We host about 300 people from all over the country every year who come in and invest in this community in a variety of ways. We have a dental clinic there. We treat dozens and dozens and dozens of patients each year at a really nice, very upscale dental clinic. We have all new equipment and everything. There's someone, we do lots of, as you can imagine, extractions. We do full sets of dentures, the whole 9 yards. This was our medical clinic, which I'll talk to you more in a moment. We have education. We do an after-school program. These are the 2 buildings that we own. We got almost 40 kids now in our after-school program. We have a housing plan. We built 1 house, and next week we break ground on a brand new 10-house neighborhood that we're very excited about. It's going to be right there. And this is our economic development center. We're all about creating jobs, which we do in that inside that economic development center. And recently, this past 2 years, we partnered with Major League Baseball to build a brand new $3 million baseball softball complex right there in Jonestown. This was opening day this past March. It is a fantastic facility. They gave us $1 million from one of their foundations. We had to raise the other $2 million in private donations. We had the grand opening, and it was really fantastic. This is a game changer up there. In these communities, there were 0 recreation leagues. Imagine that, none. So this is part of healthcare, providing kids places to exercise that are good and safe and healthy environments. So we're doing all of that, and that brings us to why we're really here today, the whole medical clinic concept. What are we doing there? Well, when we were trying to figure out healthcare, get our foot in the door, we ran across a company on the coast called Medical Analysis. And what Medical Analysis is, they're a company that goes in and they partner with large self-insured companies to put an on-site clinic there, okay? And so, and I'll name some of these large companies that they do right now. They put an on-site clinic, and the employees and their families can come. They don't take Medicare, Medicaid, or private insurance. What happens is the companies pay them a monthly fee. And what they learned is the employees love it. Their families love it. They're away from work less often, and it's driving down their other healthcare costs. Okay. And so, and they got tons of different companies that are doing this. So, and when I heard about that, I thought, could this possibly be true? And then I thought, well, if it's true, and I'm going to show you that it is, if it's true, what if we tweak this model instead of a company doing it? What if we did this with a town, a small town? Instead of a large company, what if we did the same model with a small town? And we offered where the local people could come and they could get health care, okay, in a family practice type of clinic. And we thought, what if we did that? But I wanted to see if this was true. So I called Milwaukee too, a large company. And this is what they told me. Talked to a guy named Jack. On a scale of 1 to 10, I'd give them a 12. I have nothing negative to say about them. They'll treat you right and save some lives. They send top-notch people. They're always wanting to know what else they could do. I thought that's a pretty good reference. Then I went to the Harrison County School District, which, as you know, is a large school district. Representative said they've partnered with them since 2003. We're going on a lot of years now. She raved about the service and the care provided by Medical Analysis for the employees of their 23 schools. She loved the idea of what we're doing and highly recommended them. Viking Range, you're familiar with that, said, I cannot give a heartier recommendation for Susie Bocard, who is the CEO, and her team at Medical Analysis. She's an amazing lady. We've had nothing but success with our clinic as a direct result of our partnership. You won't be anything but happy with that decision if you get to move forward with them. I talked to the city of Hattiesburg, the same thing. Talked to Southern Farm Bureau, city of D'Iberville, Bancorp South. They all said the exact same thing. And so what we did, we partnered with them. And what happens is we started out, they came in, they opened the clinic, and I'm gonna tell you how long it took them to open it. 4 days. It's like docking a box, but a really good one. They opened the clinic in 4 days. They put an MD there first. After a while, he had to leave. And then this could be controversial with some people, but that's okay. We have nurse practitioners. They replaced that with a nurse practitioner. All right. And so here's our clinic there. And here are some of the services that provide. You probably can't read that, so I'm gonna zoom in a little bit. Acute care, urgent care, primary care for all Jonestown residents at this time, chronic disease management, physicals, hypertension, diabetes, cholesterol, weight issues, smoking cessation, stress, emergency stabilization, healthcare counseling, EKGs, flu, pneumonia, Hep B, Tdap vaccines, patient referrals, laboratory capabilities, prescription capabilities, well woman exams, well men exams, asthma, on and on and on that you would get at any basic type of clinic. Also, we've had lab work there, 30 of the most commonly ordered labs. And how did it go there when we did this? Well, this is one of classic Mississippi, y'all. Classic Mississippi, a small town. The last clinic had closed 17 years prior to that. So imagine you're living in a town and for 17 years, you have no access to health care. And some people say, oh, they can just drive to the next town. Yeah, you can if you got a car. But when you don't, your cousin's going to charge you $20 to take you over there. And you don't have $20, so you're already in the hole before you get there. And so no medical care for 17 years. So we opened for 2 days a week, no Medicaid, no Medicare, private insurance. How did we pay? We raised the private money at first. We just went out to our stakeholders and we raised the money to do it. We saw over 300 patients in the first 3 months. I'll never forget the very first day I walk in there, because what it's really about is people, right? It's not about all the forms and all this stuff we talk. It's about the people. A 90-year-old man was in there when I walked in there. And on the first day, his legs, I kid you not, the bottom of his legs were, each one was about this big. He had not been able to, he lived across from the clinic. He had not been able to get to a doctor in Clarksdale or to Batesville. He was so bad, he couldn't get in his own bed. He was sleeping in an old broken down recliner. And he came in and our doctor there treated him, and because he's in the medical care, he knew about home health. We were able to line up health care. We then were able to get him a bed that was appropriate for him. And I heard that man say with my own ears, before he left there, he looked at me, he's 90 years old, and he said, this is the best day of my life. I thought, that's kind of sad. I'm glad, but it's kind of sad this was the best day of his life. And so that's the way it's working. And where I would tell you this is easily reproducible, okay? It's very good for people with no transportation. It's very good for the poor. It helps keep people out of your ER. You can open in a matter of days. You can open 2 days a week. You can do it for, I don't know, $260,000, $270,000 a year. You can do that. You can do 20 clinics for a very, very reasonable cost. Okay. And I would tell you this, just for your committee, we came up here several years ago. The speaker at the time heard about this and invited us up here. So we came and gave the presentation. He said, can you come back again? I said, yeah. We came back and we spoke to happened to be the Republican caucus at that time. Huge meeting, all of them were in there. And they said, well, this is a great idea, let's do it. And what they decided to do was in the form of tax credits, okay? And so it was written into the bill, it was passed by the House, it was passed by the Senate, it was signed into law. Well, what happened was I assumed some staff attorney drafted the bill, didn't talk to anybody else, probably copied and pasted it. And what happened, it was really, 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 really poorly written. And so an organization like us, who it was our idea, they liked it, we were written out of it. It was so poorly written. I'll give you one example. It said, Doc, imagine trying to run like this. It said the clinic, any organization like us wants to, if you have a clinic, 50%, not of your compensation for all your staff, but 50% of your entire budget has to be for a provider. Well, nobody's doing that. It makes no sense. But you could do 50% of all your compensation. I get that because you don't want it loaded with a bunch of administrators. But so nobody could do that. So as a result, we weren't able to access the tax credits. And so all I would say to you guys as a committee is this is a model that we don't think works. It's a model that we know works. We've done it. Recently, we had to close that clinic. That clinic that was reaching so many people, we had to close it because we're out of private funding. And what you discover is you go out, both government and private entities who are funders, what they want to fund is a study about healthcare. Nobody wants to fund healthcare. They'll fund a study. And what we told them is we don't need to do a $100,000 study to know that people in Jonestown don't have access to healthcare. We don't need to do that. We know they don't have access to healthcare, and they know they don't have access to healthcare. What we need is money to open it. And so what I would say from a legislative standpoint, if you can do a clinic for $250,000 to $300,000 a year, honestly, as I told the speaker that year, that's not even pocket change in the couch you're sitting on right here. And we could really help poor people in our state. And it's a model that works. We know it works, and real people get real care. And so that's the model that we do. I appreciate you listening to us today. If you have any questions, you can let me know.
Mr. Buckley, let's see if we have any questions. We've got about 5 minutes for questions.
Yes, ma'am.
Dr. Bryan?
I'll talk fast then. Well, first of all, thank you, Aaron, for bringing this excellent speaker. So I'm going to talk fast. First of all, this is an excellent model, and I would just say for the committee that from an MSMA standpoint, this would tie nicely into the Rural Scholars Program, and they've got the rural commitment to serve, and this is a really exciting thing. And I would point to the AMA data about when we put a rural physician in rural areas, the economic return is huge on the community about how it grows the community. So if we did invest in this, the data already has proven that the money comes back to us in growing the economy. It's also not really controversial that there's a nurse practitioner that goes rural. It's regarding the supervision. So as long as that's there, we don't argue that. We're excited that people get access to healthcare, period. So that nonprofits are at the table, I think is really what we're all for. So thank you for your interest in this space, and I hope that others will lean in. And I thank Aaron for bringing this to our attention. The bus concept is different, and it's taking all comers. We know we have a problem. We've got big problems. And so thank you and everyone for looking at this, because there's not one fix. So I hope that the committee will look at this thoughtfully. It's really interesting, really intriguing, and this is great work that you did. I'm excited about it.
Thank you for that. I would just say one other thing, if there's concerns about it, we could do 17 in a year. I've talked to Susie. We could open 17 in a year, but if the legislature wanted it, we could do 4 in a year. And I'll just be real blunt. Maybe people are scared because of the whole Nancy New thing. Great. We could do 4 and give you reports every single month. This is how the money was spent. Here's your report. You can come here and you can see it. We could work around those things. I'm just telling you, it ain't that hard.
again, with the staffing, when we're talking, we've got doctors, we've got young doctors that are looking for jobs. If we put our heads together, just like they could go and do the traveling thing we talked about before, if they've got a physical clinic that has been set up, we have hearts to serve, and you've got a hungry young doctor that hasn't started seeing patients yet. Absolutely, they want to help take care of people. We can make it work. We can problem solve.
That's so great. And just last thing is what we do. We go in, we're the ones that meet with the mayor. We get, they usually got a building, they're not using anymore in these towns.
Right,
Get the building, we get it all fixed up.
right.
Susie brings in all the equipment, she hires a doctor just shows up. And y'all, and what I heard some of you guys talking about earlier, all this deal about reimbursements, what doctors really want to do is treat patients. And because this model, there's no Medicaid, there's no Medicare, and there's no insurance, you know what they get to do? Treat
They
patients.
get to do what they went to school.
And they love it. And I'm sorry, I'll
No, it's your enthusiasm is infectious. Thank you.
You. Thank you. Okay, thank you so much. Thank you for your enthusiasm. We'd like to talk further with you, maybe some ideas of where you would see, if we did 4 in Mississippi, where great locations would be. And I wanted to know more about your funding model for your first facility, what percentage and where those funds came from. I'd love to talk with you further about that. Thank you. Would you, anybody get one of these? Okay, I've gone overboard on trying to get anybody in the room to give us suggestions on topics of things that we can talk about. I don't think there's any better example of that than the next subject. We're going to talk about the reimbursement policy as it relates to the QZ modifier. And I can promise you my knowledge level on the QZ modifier is very low. I think I'm going to learn a lot today. I'd like to welcome Karen Inzena Thornhill with Inzena Consulting to introduce our speaker on this subject.
Good morning, Chairman Michelle, members of the committee. Thank you for the opportunity to be here this morning. I'm here today serving as the executive director for MANA and also their lobbyist. That's the Mississippi Association of Nurse Anesthetists. I'm proud to introduce Paul Carter. He's a previous president of MANA, but he's also a highly experienced CRNA and the CEO and founder of Willa Anesthesia Services. With 25 years in the field of anesthesia, Paul founded Willow Anesthesia in 2009. Now in its 17th year of operation, the company provides complete anesthesia departments at 15 clinical sites and directly bills for insurance receivables, overwhelmingly utilizing the QZ modifier. Under Paul's leadership, Willow Anesthesia has grown to include 85 anesthesia providers, a mix of anesthesiologists and CRNAs, with a strong emphasis on CRNA-led care. In 2004, Paul proudly served with the United States Army Reserves, deploying to Iraq as part of a forward surgical team. Today, he remains a passionate advocate for fair reimbursement practices and is here to share deep, real-world experience on the QZ modifier and its vital role in modern anesthesia care. Thank you.
Thank you all for entertaining me here. And that was a tough act to follow. Like I want to write you a check before I leave. That was fantastic. And I do want to say to anyone who's curious about this, this is not a scope of practice conversation that we're having. This is purely how things are paid. And I'm going to talk to you a lot about payer parity and why it's important. Not a whole lot, by the way, but this is going to be a local community economic impact, and I'm going to try my best to tie those things together with what is an incredibly boring topic. So we're going to jump right in to explaining the QZ modifier. For those of you who don't know, anesthesia is delivered either hands-on by an anesthesiologist or by an anesthesiologist leading a team of CRNAs, or by a CRNA working in a collaborative agreement with someone and working directly with the surgeon that they're treating the patient for. Those are the ways that it's actually delivered, especially in Mississippi. So you've got these modifiers that you have to apply to the codes that you transmit to CMS. And so for the purpose of this example, we're going to assume that the payment for the code that we send in is $100. That's how much that anesthetic is worth. And that the procedure is exactly the same. AA is a modifier. That means the anesthesiologist did the case start to finish, saw you in pre-op, put you to sleep, kept you asleep, woke you up, took you to PACU, took care of your post-op care. All those other ones in the middle with Qs on them, that's an anesthesiologist leading the team. Now, what you'll notice is if the anesthesiologist is leading a team, everybody direct bills CMS. Since 1986, CRNAs have billed CMS directly and all other payers. So the total value of the case is still $100. It just gets billed out 50 to the CRNA and 50 to the anesthesiologist. QZ down there at the bottom is just, if I'm working with a gastroenterologist doing colonoscopies and there's not a anesthesiologist in the building, it's a $100 case. It's all the same payment for all the same service lines. So QZ is not an independently practicing CRNA. In Mississippi, we don't have that. It's a CRNA who's working without having an anesthesiologist in the building. That's all it means. Okay. If there's a push to cut that reimbursement significantly, and I could understand that if there was a quality reason, if there was a quality issue behind that. But in 2010, there was a study that was published in Health Affairs, and it spanned CMS claims from 1999 to 2005. It was, I'm going to go to the next slide, 481,000 patients were studied. 500,000 patients were studied. And they stratified it by those boring billing modifiers that I just went over. And they further stratified it by the physical condition of the patients. I won't bore you with it too much, but there are about 5 ASA classifications of patients. For example, if I know my next case is going to be a fractured forearm, that tells me a couple of things, but it doesn't tell me if it's a fractured forearm from a free safety at Northwest Community College who's perfectly healthy, or if it's a fractured forearm from a 91-year-old woman who fell in the nursing home. Big difference, but they stratified for all of those things. The results of the study were that there's no statistical difference in patient outcomes when the QZ modifier is billed. So there's no quality link to why they should cut this. I got ahead of my notes. So that's what we're asking you to protect. We're asking for provider parity. If you're going to give us a set of standards to practice to for a code, pay us all the same thing. That's what we're asking for. Why this is important to communities is because virtually every anesthetic practice in this state is subsidized. Either the anesthesia team works directly for the hospital and the hospital is operating that department in the red out of its own budget so that they can operate the operating room in the black, which is the driver. Or it's an anesthesia management company like myself that we agree on a set price, and whatever I can't get from the insurance companies, the hospital or surgery center makes up the difference. It's pretty simple. I'm going to skip all these. This is simple math on it. Okay. If I go to your hospital in, Boonville or wherever, anesthesia is going to be $100,000. Probably going to collect about 90. The hospital is going to come up with a $10,000 income guarantee. But if these guys cut this QZ modifier and decrease that by 15, 20, 25%, that income guarantee over there, that's coming out of your hometown hospital. And the reason that you might say, well, why don't they renegotiate their agreement with the anesthesia group? We're in the middle of a nationwide shortage of anesthesia providers. So you might be able to budge a little as a hospital administrator, say, hey, I can't go up 15,000 on my stipend to you. But you can't go too much because there are far more anesthesia positions available than there are anesthesia providers of any stripe, CRNAs or anesthesiologists, to cover them. So I'm coming at you from this as a, yes, if we're doing the same work, we should get the same pay. That's great and all. But the reality is this will impact a significant number of hospitals. I've got a list on here. Yeah, these are not all client hospitals of mine, but these are hospitals that I know for a fact bill the QZ modifier. Magnolia and Corinth, the Baptist hospitals in Union County, that's New Albany, North Mississippi, that's Oxford, Boonville, Anderson in Meridian, Atala, Kosciuszko, Baptist Leak, which is in Carthage, UMC Grenada, Progressive Health in Batesville, Northwest Regional in Clarksdale, Greenwood LaFleur, Bolivar Medical Center in Cleveland, North Sunflower in Louisville. That is not an exhaustive list of hospitals that bill out on the QZ modifier. There are a lot more and a lot more surgery centers. And I know this is not exciting stuff that we're talking about, but it is going to hit every one of those places' bottom line if they are allowed to do that. And I promised to be quick. So have I been clear? Anybody got any questions about this? Any?
Yes, sir.
I have-
So quick question for you. When you say there's a movement to cut that reimbursement, can you tell us a little bit more about that?
United Healthcare has made that announcement, and it's one of those things, one of the earlier speakers talked about being able to change contracts. They can change the terms of the contract without consulting us. They just tell us they're going to do it, and it's take it or leave it. So United Healthcare is the most recent change in that. And yeah, probably should have, it's in my notes. Probably should have mentioned that to you guys, that there is an actual push to do that. As a matter of fact, it may be going to effect in November. And it's going to hit a lot of rural facilities and single specialty surgery centers on their bottom line.
And when you talked to United about this, what do they say back to you as far as? the
They haven't
reason-
responded to a single information request that I sent to them.
Okay. Thank you.
Yeah, I definitely have a lot of questions and want to get with our anesthesiology colleagues as well on this and find out about the market impact. And I hear what you're saying. My questions are, is this private United, Medicare United? And then I understand, give or take, and Bob, you can probably help me on this, that private United's about 15% market share, right? So which is it? Is it all United? And then how, of those people having anesthesia, in reality, how much do we really expect this to be affecting the bottom line of our, because rural hospitals are important to me. So drill that down about a financial impact in reality.
It is my understanding that this is a United across the board, across all spectrums policies. I'm not under oath, so
Right.
I will verify that for you and get back to you if you'll share some contact
So
information.
we'll do some digging too, some research on the financial impact and who's doing what. And
And the big concern is if United gets away with it, everybody else is going to do it. Why would they not?
right, and then what's their reasoning? Like, are they paying for the services? Are they justifying the expertise? Because that's what they do with the 80%. Like, I know they say that. Is it expertise? Is it services? Like, I want to drill down the why, and they're not answering your question, is what you're saying.
Maybe as a physician representative, they will answer your question.
And then sometimes we have to be careful with private entities, like it's all this, they're telling us we're going to pay this for the service. We think this is what it's worth. And it's a difficult conversation. So thank you for bringing it to our attention.
Yeah, sure. All right, thanks, guys.
Always, thank you very much. Thank you, Karen. Okay, our next subject is biomarker legislation and cancer screening. I'd like to ask Kimberly Hughes, Mississippi Government Relations Director, to come forward. Government Relations Director with American Cancer Society.
Good morning, and thank you for the opportunity to present this new issue to members of the committee and members of the legislature. Like Senator Michelle said, I am the Government Relations Director for the American Cancer Society Cancer Action Network, also known as ACS-CAN, and we are the advocacy arm of the American Cancer Society. We're here to share information today about the importance of biomarker testing and how it can benefit the thousands of Mississippians currently battling not only cancer, but other diseases as well. It's a priority for our organization because it's increasingly essential to cancer care, matching patients with the right treatment at the right time and allowing many patients to live longer and better. I am going to let the physician, Dr. Pierre DeDelva, tell more about what is biomarker testing and how he's seeing it in his day-to-day practice. And then also via Zoom, I have Corey Chandler, my colleague with ACS-CAN, that will tell you how we've been working with on this policy in other states. And then last but definitely not least, we have Ashley Parker, a colon cancer survivor who many of you may be familiar with, that can tell you firsthand how this has benefited her. So, Dr. DeDelva.
Thank you to the committee for the opportunity to speak about biomarker testing, which is probably one of the most exciting things that has happened in healthcare, and particularly for cancer care in the last 25 years. So I'm a thoracic surgeon. I work at the University at St. Dominic's, but I'm here in my role as a chair of the Mississippi Lung Cancer Roundtable, which is a group of physicians, nurses, advocates, patients, survivors, their families that works to try to eradicate lung cancer in the state of Mississippi. 1,800 Mississippians will die this year of lung cancer, and it's completely preventable. And there are three pillars that we apply to try to decrease the burden of lung cancer. One is smoking cessation and tobacco control. Two is lung screening. And three is advocacy for the role of biomarker testing, because it has changed the face of lung cancer care. So what is biomarker testing? Well, when we look at patients with diseases, often we look at laboratories, which are crude. We look at tumors or tissue, and we analyze them with microscopes. Biomarker testing allows us to look at it even deeper, at the genetic level, at the molecular expression level. And it helps us to understand what is driving the disease process at the level of the cellular mechanisms. So it's more specific. And it helps us target the disease process in a more specific way. And the best analogy that I have for patients when I try to describe it is, many of my patients hunt. I'm sure a lot of people here hunt. You have a 75-yard shot. You can use a shotgun or you can use a rifle with a scope. And biomarker testing is the rifle with a scope. It lets you be very precise in targeting disease. So in lung cancer, like I mentioned, most of our patients 25 years ago, when I started my training, presented in stage 4 disease, and the 5-year survival is 5%. It is a devastating disease. It kills more people than colon cancer, prostate cancer, and breast cancer combined. And it's because not only is it difficult to diagnose, patients don't present with symptoms in early stage, but also because the treatment options didn't work very well. And probably the most frustrating job in medicine was being a lung cancer oncologist, because it was almost impossible to cure your patients. Biomarker testing has changed that dramatically. Cancer mortalities in the United States are dropping because of smoking cessation and screening efforts for breast, colon, prostate, the work of primary care physicians really trying to identify patients and save their lives, but also because of biomarker testing. And particularly in lung cancer, the biggest drop in cancer mortality has been in lung cancer. And it is because of screening and biomarker testing. So the issue that we have is that access to biomarker testing is limited. It is not always available, and there are many barriers to it. The field of lung cancer, as an example, changes on a weekly basis. A new study is coming out. It is rapid pace, and it's very difficult to keep up. So education is an issue, but also coverage differences across the country and across states make it difficult for patients and their doctors to access biomarker testing. It is estimated that by an ACS survey that 44% of patients face out-of-pocket expenses And a third of those is over $500. And 29% of patients will forego biomarker testing if the cost is out of access. And we know that older patients, Black patients, uninsured patients, Medicaid patients have less access to these medications. I'll tell you how dramatic the power of these medications are. So I'm a surgeon. I operate on cancer. I operate on patients that have early and late stage disease. There are some of these treatments that when I go and do surgery on tumors that used to be 10 centimeters, there's no cancer left with 3 treatments. And those patients have a 90% 5-year survival. 90%. Where before biomarker-driven care, their survival maybe would have been 30% and riddled with recurrence of disease and ongoing treatments. So that's an example. And I'll tell you about one of my patients, Nancy, who lives in a small town here in Mississippi. I operated on her for stage 1 cancer. Within a year, she had recurrences in her lung. She's a non-smoking woman, the fastest growing group of lung cancer patients. And she had the option of either undergoing chemotherapy or surgery to remove the remainder of her entire right lung. Pretty significant operation. We thought that because she was a non-smoking woman that she would have a biomarker. So we had to fight because she didn't quite at the time fit the criteria for it. We had to fight to get her biomarker testing. And indeed, she had an actionable mutation, meaning that there was a mutation in the tumor, that there was a drug in the shelf that could treat it and control her cancer. So we did that and avoided a pretty major operation. 4 years out, she's cancer-free. During that time, she had issues with getting coverage for her medication, and she had to go fight and with her insurance company and with her team to be able to get access. And she came to speak at our annual meeting of the Mississippi Lung Cancer Roundtable, and she said, you know, I had to fight. I'll say the name of the medicine because it sounds, those are her words. Nobody's going to take away my Tagrisso, and nobody's going to take away my hope. Those were her words. And she had to fight for that through the system and the things that we've been talking about today. So biomarker testing is an incredible, powerful tool to personalize medicine and to make precision medicine and to save lives. In lung cancer, in particular, it's creating survivors where we didn't have them before. And as Ashley will speak to, in colon cancers have an effect, in pancreatic cancer, melanoma, in a number of diseases. And so, but there is an equity issue for access to biomarker testing, and we're looking for help in every way to try to decrease that disparity so that everybody has access. So ultimately, particularly when it comes to the care of cancer, effective therapy saves money and saves lives. Ineffective therapy, in many ways, adds little to life and costs a lot of money. So if we can bring the most effective treatments for patients, everybody wins. So thank you. I hope that explains a little bit what biomarker testing is, and I think you'll get even a better feel for what its impact is from Ashley.
Good morning, everyone. Just want to confirm you can see my slides. Oh, I think I see them on the screen. Can you hear me?
Yes.
Yeah. Fantastic. Okay, thank you so much. Really appreciate the opportunity to be here with you all this morning. And thank you, Dr. DeVelva. That was a really helpful overview and a good kind of segue into what I have to share. So my name, as Kimberly mentioned, is Corey Chandler. I am a senior state and local campaigns manager. So I'm on the Access to Care team at the American Cancer Society Cancer Action Network. So in my role, I am supporting legislative campaigns and work happening around the country on specific priorities, including biomarker testing. So Dr. Delva highlighted it a little bit, but I just wanted to cover quickly who should be getting this testing. So doctors are often looking to clinical practice guidelines to determine the most appropriate biomarker test for a patient. So these guidelines are continually updated, and that's really helping to assure that like he mentioned, that we're keeping up with the latest advancements in taking advantage of the latest in scientific and medical evidence. So these practice guidelines are published from a variety of organizations. So examples include the National Comprehensive Cancer Network, that's NCCN, their clinical practice guidelines on oncology, and those are the guidelines that are actually most often referenced by oncologists. And then ASCO, the American Society of Clinical Oncology, also has guidelines. But as the doctor mentioned, for some cancers like lung cancer, biomarker testing has really become the standard of care. And studies have shown that patients who receive biomarker testing and are eligible for and receive targeted cancer therapies have better outcomes. So that's really the crux of the issue here. But as the doctor mentioned, currently we are seeing a variety of disparities in who is able to access that testing, and that's based on race, age, location, and socioeconomic status. So we know that communities that have been excluded include communities of color, individuals with lower socioeconomic status, rural residents, and patients receiving care in non-academic medical centers. Those patients are all less likely to receive biomarker testing. So improving coverage for and access to biomarker testing is really key to reducing health disparities. And again, as the doctor mentioned, there are many barriers to use and really to gaining access to a targeted cancer therapy. And the reason we chose to address this specific barrier, the biomarker testing coverage barrier, is because this is the one that can be addressed through state legislation, and state legislation cannot address all of these components. So to get a little more in depth on the actual barrier, currently many patients who should be getting tested are missing out. So as I mentioned, insurance coverage can be a barrier. So as far as what that coverage currently looks like, most plans cover some biomarker testing for some patients, but there are gaps between what tests are covered and what tests are needed based on clinical treatment guidelines like those from NCCN, so the clinical practice, that organization that issues the clinical practice guidelines that I mentioned. And often coverage is limited based on the size of a particular test and not necessarily tied to the level of evidence of the test. So these differences in coverage actually contribute to disparities in access, as you would assume. So we are actually there's a study comparing each state's largest insurance coverage policies and those NCCN clinical treatment guidelines. And the study shows that most plans are more restrictive than NCCN treatment guidelines for multi-gene panel tests. And so despite the fact that 91% of insurance policies actually report referencing those guidelines and determining what tests to cover, this paper demonstrates that plans are not following the science, and many patients who should be getting biomarker testing are likely unable to because, as again the doctor mentioned, the costs are too high because these tests are not covered. And 71% of policies reviewed were more restricted than NCCN guidelines for 4 types of advanced cancer. So we did have state-by-state numbers as well. So in Mississippi, the policies that were more restrictive is actually higher than the national average. It's 74% of policies reviewed were more restrictive than those guidelines. And we do have some data on the provider experience as well. So a recent national survey of oncology providers that we performed found that insurance coverage and cost concerns are top barriers to appropriate use of biomarker testing for their patients. 66% of providers actually reported that the patient insurance coverage for a desired biomarker test is a significant or moderate barrier. So as a policy solution, we have been supporting legislation and introducing legislation around the country to address this coverage issue. So 2 things are probably clear at this point from the doctor's remarks and what I've shared. So obviously biomarker testing is really critical to patient care, especially in this cancer space, but in other diseases as well. And there are real barriers to patients receiving the testing that they need. So as I mentioned, states have been pursuing legislation to ensure biomarker testing is covered when there is clear medical and scientific evidence supporting those applications. And I want to be very clear that this is not universal coverage of biomarker testing. ACS CAN would not support a bill that required all biomarker tests to be covered. So this only requires coverage for specific purposes outlined in the bill. So that's for diagnosis, treatment, appropriate management, and ongoing monitoring, and when the test meets a rigorous standard of scientific and medical evidence. And just to be clear, when we say diagnosis, we don't mean diagnosis in the sense that we're screening healthy individuals for a specific disease. Diagnosis is used in the way that we are looking at a patient that is already sick, so a patient that has been diagnosed with lung cancer, and again, looking for that specific actionable mutation that the doctor mentioned. So a mutation that would help us figure out what the best treatment is for that specific patient. So this is not going to provide coverage for biomarker testing for screening purposes. And it's also important to note that, as I mentioned earlier, current coverage isn't an all or nothing proposition. So as far as the impact of the legislation, we're accounting for the small population of people who, one, need biomarker testing. So not all individuals diagnosed with cancer will necessarily need a biomarker test. And then two, for whom it is not already covered. So insurers are covering some of this testing, but not necessarily the test that a specific patient needs. And then it's also worth noting that there is evidence that an increased spending on biomarker testing actually yields significant savings on overall treatment costs by avoiding unnecessary or ineffective treatments. So as far as the current state of play, 22 states have actually passed legislation at this point that would require coverage of biomarker testing when it meets those conditions that I mentioned previously. And there is very broad support for this legislation as well. So this is a disease agnostic bill. Biomarker testing is used it does have non-oncology applications. Alzheimer's is a really close partner of ours. There's biomarker testing that's applicable in the Alzheimer's population, as well as arthritis and other populations that it's incredibly important to chronically ill patients. So at this point, I'm going to pass it over to Ashley, and I know she has a personal story to share that will really demonstrate the impact this biomarker testing has on patients.
Hi, thank you for having me. I appreciate it. I'm honored to be here to be able to speak from somebody who has been in the trenches, so to say. When I was 48 years old, I was diagnosed with colon cancer in 2019. So at that time, the colonoscopy screenings were recommended at 50. So I wasn't late on any screening, but I was having issues. So I went to the doctor, and like Dr. Underwood said earlier, I woke up from a colonoscopy to find out that I had cancer. And then as testing went further, it was discovered that I had stage 4 colon cancer. I had, it had spread to my liver. I had 3 or 4 spots in my liver, and it was in my lymph nodes as well. I was given not by my doctor, but by general study, about a 12% chance of living 2 years. And that's just living, not thriving or anything like that. I'm here today, and I am thriving. And I say that a lot of that, I give that glory to God for that. But my healthcare providers really hit it hard from the get-go. You get, from what I have gathered from all the cancer survivors that I've mentored over the past 6 years or so, you get one first shot at cancer, one first throat punch at cancer. And it better be a good one, and it better be the right one, because you don't want to take the wrong medicine and then that weakens your body, and then you realize, oh, well, that didn't work. Let's switch over to this. Well, when you are given biomarker testing like I was, it showed that I didn't have any gene mutations. So I could be given the gold standard, the first approach of FOLFOX chemotherapy, and I went through that for 3 months. It shrunk my cancers in my liver enough that I was able to have liver resection. Had 20% of my liver removed, and then I ended up going through 25 treatments of radiation, 5 days a week for 5 weeks in a row while I took oral chemo at the same time. I recovered from that, and I had my surgery where I had that part of my colon, the part of my rectum, the primary tumor removed. I have a permanent colostomy, and I monitor now. After that, I was cancer-free for close to 3 years. We monitored that with CT scans and blood work, and I also had ctDNA testing done. Close to 3 years, one of my ctDNA tests came back that's in the biomarker umbrella. It came back positive, which was very shocking to me and my doctor at the time, because I was getting so close to a 3-year freedom. And he ordered a PET scan. I had a 2-centimeter spot that had popped up on my liver. I was able to have that taken care of with microwave ablation instead of having a liver resection done. It has taken care of that. I've been cancer-free for the past 2 years. We still monitor with the ctDNA testing. I made an agreement with my oncologist at the time, because before that ctDNA testing came along and you could monitor it that way, how you would normally handle that was, oh, you're a stage 4 colon cancer patient. You've had something pop back up in your liver. You're going to be on chemo for life. I'm 54. Our youngest child is 15. The mental toll of going through cancer treatment and surgeries and watching your kids be sad and going through all those things is one of the worst things I've been through in my life. And to come across the time when I was given the opportunity to, you can do this testing and we can monitor you this way. And it's obviously proven very good, because that 2-centimeter spot that sorry, that 2-centimeter spot that showed up in my liver, it was not, you could not see that on a CT scan. So the ctDNA testing that they have come out with, you can detect a spot that has come up 6 to 18 months before it would show up on a CT scan. So you're given the chance to get something when it's small. When I had the liver ablation done, I was back on the tennis court in 3 weeks. When I had my liver resection done in 2019, I was still taking 2 naps a day 6 months after, and I only had 20% of my liver removed then. If I had not been able to have the microwave ablation done in 2023, they would have had to resect at least 50% of my liver. I don't know if you know anything about a liver resection surgery. It's not the easiest surgery to go to. It's quite dangerous. You have a lot of complications that can happen. And the biomarker testing at the beginning, allowing them to know which cancer treatments would work the best, my body being a good responder to those as well, and the dedication of my doctors and nurses to get me through all of these battles is one of the reasons that I'm here today. I have mentored since a girl that lives here in Mississippi. She's a colon cancer patient as well. Her doctor would not do the ctDNA testing. And by the time she had a liver lesion pop up that was able to be seen on a CT scan, it was already 4 centimeters. So it was past the line where you can have an ablation done. So she had to have a liver resection. She's a single mom. She takes care of her kids, lives by herself with her kids. Those things it doesn't have to be that way. And I feel like everybody deserves the high level of care that I received. No matter where you live, what color you are, how much money you have in the bank, everyone should receive the opportunity to live and thrive like I am now. And I just hope that y'all can continue to study and hopefully make some changes this year that will allow people to live. That ctDNA testing that I have, I guarantee it's a lot cheaper than me being on chemotherapy for the rest of my life. Because I'm 54 and I'm going to be here for a long time. And I'd hate to have to pay that bill. So thank you for having me. If anybody has any questions, I'll answer them or.
I have a question for you
Huh?
and or Kimberly. Of the states that have enacted the legislation, is there one particular law that you think they did the best job of enacting the legislation that's most effective, number one? And then number two, do you have a model bill at NAIC or NCOIL?
Yes, we do have some model language that we'll share with you. And Corey, I'll let you answer the question about any particular state to look to.
Yes, that's great. That's great. Thank you, Kimberly. So all of the legislation, as Kimberly mentioned, we have a model bill. So all of the legislation is very much very much similar. So it reflects our model language with just small changes to align with the state statute and the way they write their statute. And then, yeah, the answer to your NCOIL, we do have model language, a model bill in NCOIL. CSG has endorsed the language, as well as there's another caucus as well, the Hispanic caucus as well, congressional caucus.
And you do have some handouts. I hope everybody received a copy. Corey shared a slide of the many national groups that have signed on to this, not just cancer related, but we do have several Mississippi groups that have signed on in partnership that we'll be working with over the next few months. And those are, that list is updated on your handout so you can see the groups, that'll be working with us. But we know this is a new issue to a lot of people, so we'll continue to educate and work over the coming months on the importance of this issue as we get ready for the session to start in January. Any other questions?
Be able to do one other thing for us, please. One of the states that has had this law enacted for several years, could you get a cost analysis to their state health insurance plan so that we could maybe extract some numbers for the size of our plan versus where it was enacted?
Sure.
We're required to have that information if we're going to pass legislation, or it can kill the bill on the floor if we don't have a cost study.
Right. And we do have some cost studies that were done that we'll get you and continue to work on that information. Corey, anything to add on that?
Yeah, I can add. So we do have an actuarial analysis. We did have one independently done on the bill as well. So that showed that the cost for private plans would be 14 to 51 cents per member per month. And so that does include the administrative costs and additional profit the insurers would factor in there. And then for Medicaid, it was 4 to 9 cents per member per month. So we can share that information too.
Other questions for any of us? Okay, thank you.
So much. Okay, members of the committee, I want to reiterate, please fill out any request for subjects that we can discuss at our next couple of meetings. Next meeting is Wednesday, October 29th. We're not able to get this room in the morning at the time we've been meeting, so it will be held at 1:30 in the same room on October 29th. We'll have another full agenda. We have some people that have asked to be on that already. We've got spots for a couple more presentations. I thank you very much for being with us today. We stand adjourned.